If you feel like you've done all of the standard testing and you're still not getting pregnant, just to even know, okay, what else is out there for me to explore?
Welcome to the Advanced Women's Health Podcast, where we empower women with the latest insights and advice on holistic health. From cutting edge medical research to practical wellness tips, our mission is to help you thrive at every stage of life. Join us as we explore topics ranging from hormonal balance and reproductive health to nutrition and mental well being. Whether you're seeking solutions for a specific health concern or simply want to enhance your overall wellness, you're in the right place. Let's embark on this journey to better health together. This is the Advanced Women's Health Podcast. Before we dive into today's episode, I wanted to let you know about some exciting things we have been working on at Advanced Women's Health. So we don't aim to just be excellent at appointments and excellent with the care we give to patients in terms of the protocol. But our goal is cross-clinic excellence. We want to ensure that you are getting the most wonderful onboarding experience, that you feel supported, and that fundamentally you actually are going to implement your plan. We talk about health being a lifestyle, and it is, right? It is something that needs to be modified or shifted. We need to think about things differently. We need to understand our bodies differently. We need to have those education-based aha moments or those community-based aha moments to be able to action what we know to be true and what we know we need to do. And so over the last few years, we have been consistently evolving and trying to give you the best patient care experience possible. And that has resulted in us having our new patient onboarding system. All new patients at Advanced Women's Health now get access to a plethora of resources. We go through educational pipelines and daily tips and tricks that will help you to implement your plan. We have mindset support. We have onboarding coordinators that are there to create community and hold your hand in live QA calls. We offer meal templates and meal plan structures, exercise videos and programs, community challenges, and so much more. And again, this is just included as being part of a patient of Advanced Women's Health. So if you have been on the fence, if you have been hesitating, book with one of our patient onboarding coordinators. We are here to help you pick which practitioner is the best fit for you. And then you can learn more about our onboarding systems and everything else we offer at Advanced Women's Health. So now to the episode. Hello, everyone, and welcome back to today's episode of the Advanced Women's Health Podcast. I'm here with Dr. Lauryn Dingwall in Kingston. We are chatting all about fertility as we continue our fertility series. So thanks for coming on and allowing me to force you into this conversation, Lauryn.
Thanks for having me.
So today we're going to talk specifically about the immune system when it comes to fertility. And we've already talked about ovulation, and people literally think, like even a conversation I had with a patient yesterday, okay, if egg and sperm meet, then you're pregnant. And the reality is if you're ovulating, that's critical. And if there's healthy sperm, that's critical. We can get into egg quality conversation, even though it's hard to measure. But there is that piece of it that is so the beginning, right? And I have patients, they tell them, I'm like, you technically could fertilize an egg every single month and not be pregnant because the immune system is such a huge part of how we get pregnant and sustain a pregnancy. So I want to start there. That's a foreign concept to a lot of people. They think about the immune system. They think about getting a cold or a flu. They think about your knee swells up or they cut themselves. It's red, hot, inflamed. That's what the immune system does. But what's going on with respect to the immune system and fertility?
Yeah, it's actually really interesting because the immune system is involved really at every step of the process, which I think is sometimes a bigger conversation even from what I see online. And we're starting to have more conversations around how the immune system is involved with implantation. So once there's already been fertilization that's happened and the embryo is traveling down to the uterine lining to actually start to invade that lining and make its little home, But we really kind of see that the immune system can impact follicular recruitment, so kind of what follicle the ovaries are choosing to ovulate that month. The immune system is involved with whether or not egg and sperm are even going to meet. So we do need the fallopian tubes working properly. We need that movement, how the fallopian tubes are catching the egg to actually bring the egg down to support fertilization and then continue to bring it down into the uterine cavity. And it's really interesting that the immune system can affect how these little like finger-like projections, what they're called cilia, but essentially how well they can function and essentially the movement or how they're facilitating the direction of movement for that as well. Fundamentally, the immune system is deciding and a checkpoint for how do each of those steps happen and deciding more or less, is it going to let your body proceed past go is how I think about it, which each of those processes. So we need this series of really coordinated messages within the immune system to allow us to proceed to the next step. And if the immune system isn't behaving in the predictable way that we would expect, it can be that stopping point and we can't move to that next step along kind of all the events that need to happen.
And one of the things that I think is so fundamentally important, because when we're talking about any condition, let alone fertility, the important thing to remember is that most of the time the body is right. And so if we take that on as our reality, that your body is doing something correct, it is doing something that it views as protective, it is doing something that it views as opportune, right, to deal with an underlying factor. If we believe that to be true, right, whether that's currently or at a certain point it was correct, then that just gives us a different lens to look at. So if we say, okay, the immune system is not wanting, it doesn't have desires, but let's just use that term, not wanting someone to get pregnant, why would that be? Right? That is because they have an underlying infection that would make it risky to carry a pregnancy. That could be that there is a pelvic infection. Right? That is a risk. That could be that mom's health is at risk. There's so many different pieces because again, it's not thinking logically, it's reacting to the environment. And when we have so many different immune influences, and we could go so far down this path, current infection, current virus, past infection, past virus, that confuses the system and makes it think there's still inflammation, bacteria, right? All of the organisms in between.
I was going to say like history of any autoimmune conditions, endometriosis, adenomyosis.
Yeah. And that's the thing is when we look at autoimmune conditions, what is that? It's simply your immune system thinks a tissue is a bacteria or a virus or some kind of microbe that needs to die. And so it starts to get confused and attack it, but it still thinks it's helping you. When we look at endometriosis, there's an immune underpinning to that, right? There's a genetic factors for sure, but somewhere down the line, the immune system decided that it should let endometrial-like cells grow, get their own blood flow, get their own nerves, and proliferate. That shouldn't happen, right? Just like cancer shouldn't be allowed to grow. I'm not saying they're the same thing, everyone. Don't hit the panic button. But, right, cancer is a cell type that's abnormal, that shouldn't be there, that's growing out of control. These are things that our immune system should sense and be like, you shouldn't be here. You shouldn't do that. When we look at adenomyosis, right, it's that invasion of the lining of the uterus, essentially, in the space between, right? It's getting into the muscles. It's essentially dramatically affecting the environment there. These are all immunological factors. And so when we're looking at fertility, I say like you're lowballing it if you say 50% of infertility is due to the immune system, like lowballing it. And that's an area that one is not talked about too much because two, there's very few protocols in existence that show that you can dramatically impact it with pharmaceuticals. In the world of nutraceuticals, we have more options. We have more expansive opportunities. We have more opportunity to look for the trigger, understand, deal with repetitive triggers. But there's really just such a limited pool of research available on immunologically modified agents And so they're not commonplace yet from a pharmaceutical perspective. And so it's just not, people don't know about it, which is so sad.
And I think the other piece is there are some clinics that are using more immune modifying agents, but when we look at the pharmaceutical action of it, what it's telling us is, okay, is someone's immune system really active? And it's just looking to put a block to that, which it definitely has a time or place. But I think where we want to hold that curiosity and explore that a little bit more is understanding, okay, why is the immune system behaving that way to begin with? And obviously in certain situations, there's a time sensitive kind of manner, or you're in the middle of a transfer or something like that, and you don't always have the opportunity of time in your favor that you're looking at reprogramming the immune system for 3, 6, 9, 12 months minimum to be able to hit into those. So I can appreciate that it's not always as easy as saying, okay, let's actually try to understand, was it a bacteria, a virus? What was that never since point that the immune system started behaving a bit more promiscuously? That sometimes we are just kind of using pharmaceuticals to say, okay, we see that attack, that Th1 dominance was just essentially attack everything. Okay, we have pharmaceuticals that can just bring that down. Okay, we see different NK cells, and same thing, they're not as specific, but it's essentially just like attack. Okay, what are some immunological agents we have that? But again, it's that, but why to begin with? Are we missing a bigger picture? And is there anything we can do integratively and even outside of using those agents that we can work to support?
Yeah. And we do really run that checklist, right? We say, okay, what's the history of infection? What's the history of any STIs? What's going on with any potential triggers, the vaginal microbiome, the cervical microbiome? I know there's lots of conversations about the endometrial microbiome. I'm not convinced that we have a great way to understand that yet. I know there's testing, but it's how much is it reflecting the cervix and the vagina, and how much is it reflecting what's actually happening in the uterine lining? I think we will find that information soon, but we don't have it yet. Then we have what's going on in the lining, right? And that, like the immune cells that are there outside of the bugs. And then we get into what's the fluid that all of these tissues are bathed in, the peritoneal fluid, right? So when you're starting to go through and start to understand that as a clinician, like what types of questions are you asking? What types of things are you looking for to start to tease apart where these sources of inflammation may be hiding?
Yeah, I think first starting with just some signs or symptoms. So things right off the bat that I say are big red flags that we already start to be curious around if inflammation or the immune system is involved to some consent or some part of it, would be any signs or symptoms of pain. So pelvic pain, painful periods, painful bowel movements, low back pain that cycles, painful urination, any history of infections. So do you get a lot of UTIs? Have you had a lot of yeast infections, bacterial vaginosis, STI, STD history, abnormal pap exams? You do have a history of viruses. So did you get COVID? How did it impact you? What were some symptoms you experienced after? How was your recovery? Do you get cold sores? Have you had mono? Looking at kind of some of those pieces as well, set before we even start to look at lab work and investigation, already kind of cycling through some of those questions. Do you get any weird rashes? Headaches, migraines? We know there's components with that as well that we already start to build this picture. And a lot of times we see that those people have been told they have unexplained infertility because it's like, well, like you said, you're ovulating, your reserve looks solid, sperm look good. We don't know why. Something's just not lining up. So obviously the immune system being something really underdiagnosed in that capacity, but even if someone's at the early stages and they have yet to even receive that label, or they're getting some diagnosis, those are all some things that we're like, okay, what's going on here? And kind of asking a little bit more information too about digestion history, how are bowel movements, gas, bloating, mucus in the stool, any travel infections that we see, or if you live in Kingston, that nice parasite that went around all the last
so many of
months.
Our patients,
But those are all things too. And again, I think this is something I know we've talked about as a clinic, but getting an acute infection doesn't always mean that you have an immunological dysfunction, but it's what happens afterwards that tells us more as well. That is like, was that a never well since? Did you have a symptom that lingered for a really while? Did we see that impact resilience? Did your immune system able to fight that? Okay, then it went back to normal and everything's good to go. Or did we see things really kind of, it struggled to get back to a place of homeostasis or kind of like balance?
Yeah. And when we talk about inflammation, obviously we look at it in so many different ways. There's local inflammation. So that's where we're talking about what's happening, ovaries, the peritoneal cavity and fluid. We're talking about the uterine lining. We're talking about these things. But then there's the systemic inflammation. So that's where people don't think they're fatigued, their brain fog, their low motivation. Like some of those symptoms, their rashes, have any impact on fertility because we're in a system that we're so used to siloing everything, right? So it's just, okay, you go here for this medication, you go here for this investigation, you go here for this, you go here for that. But fertility is really a situation where we want to bring all of those forces together and say, okay, at the end of the day, and I've said this so many times and I'll say it again, babies are miracles. Like it doesn't make any sense. Right? Why would you allow your DNA plus someone else's to embed in the lining of your uterus, grow its own blood flow, take over its supply, steal all your nutrients? It makes no sense. Biologically, it is the weirdest thing that is ever in existence. And so we have to acknowledge that and hold space for that in the room when we're looking at fertility, because there is a reason why the immune system has woken up to the fact that this is crazy. And if we can find where that lies, then we have a lot better opportunity. But it takes looking systemic because sometimes we have patients who have no pelvic symptoms. They do not have pelvic pain. They do not have pain with periods. When you're running the list, there's not a lot to work with in that local area. And so we really do have to zoom out and say, okay, where are the other signs and symptoms we're getting into? And then also, what are the labs telling us? Because that is another big thing where you can have silent inflammatory responses. It's not always screaming at you. I always say, as someone who has endometriosis, who it can cycle, some months is completely fine. Right? Fortunately, in my life, many months is totally fine. But then out of nowhere, you'll get hit with something. And it's not that the inflammation and the endo wasn't there the whole time. It was, right? It's just something, whether that's a virus, margaritas, whatever that is, has flared. A girl can be honest. But it's contributed to a flare. And so in that moment, we see those symptoms. But I think it is a really good example because people can be sitting here saying, well, I've been trying to conceive. I have none of these symptoms they're talking about consistently. So this is still doesn't apply to me and can be unexplained. But you and I both have so many patients, there's not a lot to deal with. And then they get opened up and they're riddled with endo. Or again, like they go for imaging and they have kissing ovaries and adenomyosis and all these things. So we really can think about it differently when we're looking at these common factors with the immune system, but it takes that investigation first.
Yeah, and it is really scary, like even kind of bringing it up with patients when you're in visits. Sometimes it just takes a little bit to even wrap your head around that you're like, what do you mean? Because it's something that throughout kind of their whole journey before they get into our office, no one's ever brought up to them. So it's like this whole new concept that we're throwing at them and then equally doing a little bit of a crash course on physiology and just letting that sink in. And they're like, oh, wow, I didn't even realize that there's this whole other kind of part of what could be impacting me getting pregnant or staying pregnant. So both of those pieces, because we'll see it both in getting pregnant, but also maintaining the pregnancy.
So before we get into lab tests, let's run some terms that people will have heard, right, when they're coming here. So one of them being endometrial receptivity. What is that? What does that mean?
Yeah, endometrial receptivity is essentially how receptive the uterine lining, so the endometrium, is to the incoming embryo. So what we want is, obviously, I always kind of joke with patients that it's like you want your uterine lining to be like, yep, no problem, come make a new home here. So they're very welcoming, the door is open, and everything's ready to go. So then that way, whenever embryo and uterine lining meet, that embryo can actually start to invade and take up a new home in that uterine lining. So that's what we're thinking about with endometrial receptivity. There's a lot of different steps that kind of have to happen. So that initial kind of connection, that initial invasion, and then the change to the immune system to allow that embryo to continue to grow from there. So obviously there can be different pieces along that, but that's essentially fundamentally what we're looking at. Is the uterine lining receptive to that incoming embryo and allowing it to take up space and home in them?
Yeah. And then with endometrial receptivity, sometimes you'll hear they'll use embryo glue and like things like that. From your perspective, does that dramatically impact the outcomes if we have an immune system response?
Yeah. No.
Yeah. Wanted to ask the questions the listeners are following us here. But
yeah, I know a lot of clinics kind of recommend it as an add-on to potentially give an additional factor that they can modify to essentially encourage that adhesion and kind of meeting between embryo and uterine lining. I'm not super convinced with the research that it's the factor that reproducibly creates a superior response. If someone wants to do it, I don't think there's a lot of risk or harm. So I know there's certain clinics that they do it as part of their protocol with a transfer regardless. So it's not really something that you have to pay additionally, whatever, $600 or $700 for. And in those scenarios, I'm like, I don't think it does harm. Am I convinced that it's the thing that's going to give you an added benefit, especially if there are some of these underlying mechanisms? No, it's probably not our main factor that's going to determine yes or no you're getting a positive pregnancy test.
Yeah.
Or that's my opinion anyways.
Yeah, no, I think when you take an immune system perspective, it changes a lot of things, right? So there's a lot more research coming out on something we call like motility. So essentially similar to what Dr. Lauryn was talking about before, we need to see that egg get pushed along. It's like an assembly line, right? From your fallopian tubes into your uterus and then to find the right spot in your uterus. And so there's newer research coming out on adenomyosis specifically, but some other conditions as well, showing that those assembly lines are clunky. They're not moving very well. Things are not moving in the right direction. Sometimes they move backwards, right? Like there's all those types of things. So if you do have a motility issue, meaning things aren't moving in the right direction, they're going too fast, it's essentially preventing the embryo from getting where they need to go. Sure, maybe sticking it where it needs to go and holding it there is not a bad idea. But when we're talking about the fact that those conditions are often associated with immunological issues as well, that's when it's like, okay, is it making that much of a difference? But these are the types of questions I'm getting more commonly.
Yeah, and it's really interesting. There's something called like a ciliary beat frequency, which is essentially had measured the rate at which both the direction and the rate at which that movement happens. And in a lot of those conditions, we'll actually see that's altered. And even some research in PCOS, which is really interesting in kind of a heightened androgenic, or when testosterone is flagged high, or DHEA, which are two male hormones, or androgenic hormones as a female, are flagged high. That can also separate, because I think a lot of times, again, we talk about endometriosis and adenomyosis as the primary kind of conditions where we think of that immunological dysfunction, but it was interesting in some of the research to see that piece too, because sometimes we just think about PCOS as kind of an ovulatory disorder from that perspective. So it still can be other factors that are impacting that motility.
Yeah, and I think like PCOS or PMOS is such a good example because it's an inflammatory condition at its core as well, right? Yes, it's metabolic, but there is, with metabolic dysfunction, there's inflammatory dysfunction. And so you do letrozole, right? Or you do an IUI and it's like, this should solve all the problems, and it doesn't. And then people are getting more and more overwhelmed because they're like, well, I'm ovulating. What next? And so I do think it's really important to open people's awareness to the fact that these are not just simplistic things.
Yeah, and I'm sure we've all had patients where they go for an HSG and then the next month they get pregnant. And I think part of that is if there is either a bit of debris or the fluid sitting in the fallopian tubes, there is a bit of that inflammatory component. It's an opportunity for a quick reset. So if that environment can change for the next cycle, and I think it's a small window of time, because then if the underlying factors which led to that, we're just going to see that come back. But we have seen multiple patients where that's part of the case. And I think that's a bigger factor with why we see that sometimes. Yeah, because it's just a little bit of an opportunity to modify that environment.
Yeah, 100%. Other things that come up is recurrent implantation failure, or RIF. So what does that mean?
Yeah, so I kind of group it in the same thing, that it's technically, we use that more so in the IVF setting, and it's when we've had repeated transfers and we haven't gotten a positive beta. So I forget what the definite, I think it's three or more technically. They won't often, I believe that's the threshold, but I could be wrong. But normally we're looking at multiple transfers that haven't resulted in a positive HCG, so a positive pregnancy test. So that's when they start to say, okay, when we're thinking about that endometrial receptivity, something's really not clicking there, that we are unable to get that embryo to implant. Because up until that point, we've essentially modified and gotten someone all the way to the point where they have an embryo. So those first few steps, we've already overridden and manipulated in a controlled setting. So that last step that we need to happen is for the uterine lining to say, come on, little embryo, and welcome it with open arms and make its new home. So recurrent implantation failure is essentially the fact that's not happening repeatedly. And again, it brings us back 99% of the time to the immune system and why we're not getting the immune system to behave in a way where, again, we're getting the attachment, the invasion, and then a quick adaptation.
I always say, I grew up in the country, everyone, so forgive. But if you get a leech on you, right? You know what I mean? It's like it has to bite into the skin. That's an inflammatory response, right? And now there's all these weird leech treatments and things people are doing to reduce inflammation. And I'm not about it. I've had enough of those suckers on me. I'm not interested. But if you picture it that way, it's like you have to create an inflammatory environment to bite in, to get blood flow, to do what you need to do to get the nutrients. And then the immune system has to very quickly be like, oh, this isn't a leech. It shouldn't be popped off. It should be allowed to stay. So that's that whole process. And then again, grow and develop in all these things. But the big point I wanted to make with that is RIF is not a diagnosis. It's an outcome. And we'll have people that are like, oh yeah, I have recurrent implantation failure, as if that's their diagnosis. And I'm like, no, that's what happened. It's the outcome of multiple treatments. That's not a diagnosis. And now we treat that from an immune system perspective and blah, 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 blah. But we need to remember fundamentally that when I ask you what your diagnosis is and you say RIF, it's not a diagnosis.
Yeah.
Right. Same with RPL, right? And again, these are fertility terms. Like you start to speak a different language when you live in the fertility world. But recurrent pregnancy loss, or RPL, right, means that you have been able to have the implantation occur, but then it hasn't carried forward to a viable birth or a live birth, right? So when we're looking at recurrent pregnancy loss, how does the immune system factor into that?
Yeah. So essentially, I kind of think about it in the same spectrum, is that we will get that initial invasion, but we need ongoing kind of maintenance of the immune system. So then that way it's not starting to grow and develop, and then the immune system says, nope, you're gone. From that perspective, there's a couple other variables that sometimes we'll see, and some of these terms are probably a bit more complicated, but I know this is where sometimes they'll look into what we call an alloimmune response. So essentially how mom's kind of immune system is responding to dad's immune system in that environment as well. They're looking at, again, that balance between an overactive immune system, what we call T regulatory cells, which kind of just keeps everything in check, and then our Th2 response, which is more kind of that adaptive, parasitic, like I always hear you say, cutest little parasite you'll grow from there.
They remain that way. Just I'm still parasites coming into my bedroom at 4:45 in the morning. So yeah.
And then Also, we think about it in the sense of clotting concerns and issues and how the placenta and spiral arteries are forming. So it can either be the immune system saying, okay, you initially get that attachment, but then it says, no, get away from me. Or it's how the immune system is altering how that organ is forming that's responsible for delivering blood flow and nutrients to the little baby that's growing. And any kind of subtle change there can be enough that in that really vulnerable stage, we end up seeing that the embryo stops growing.
Yeah. And we're going to talk all about circulation because that's, again, such a big piece of the conversation is what's happening with the circulatory system, whether that's in the ovaries, whether that's in the uterus, all of those things. So we'll get to that conversation for sure. Since we started Advanced Women's Health, we got one consistent question. Will you treat my partner, my boyfriend, my husband, my friend? And we have always had about 20% of the advanced women's health population of patients being male. But we know that our lovely men want a home of their own. They want focused evidence, focused treatment, and they want an opportunity to engage with a practitioner that is just relatable. So we launched Advanced Men's Health last year, and it's been a growing project across our Ontario clinics. Men need specific types of support, specific types of coaching, but what we heard from patients all the time is when their partners were seeing someone else, they may have conflicting plans in the home. They may be in a situation where their partner's told to eat one dietary approach and they're told to eat something different, or their partner's like, this insulin thing sounds really cool. I want to understand, or I want to get the same gut treatment as you, but I don't know if that's indicated. So again, we have created an opportunity to have the same pillars, the same frameworks, the same understanding, and the same style of approach so that families can get well together. Because fundamentally, that is something that we know in the research, we know in practice, is so effective, is when couples, when teams, when people work together and they hold each other accountable following a similar plan. So if you have a partner who is interested in care, you can reach out to the Advanced Men's Health team or see advancedmenshealth.ca for more information. Our team is consistently expanding. Right now, we are operating out of Ontario, but soon we will be in BC, and even sooner, I'm sure we'll be expanding to other provinces. If you want to get your man healthy, then we have options for you. Now back to the episode. So then let's look at from a lab perspective. So someone's coming in, we are thinking, well, they haven't been pregnant, right? And so we're sitting here saying, okay, chances are this is what's going on. And this is how we now need to be able to help them navigate and understand that their immune system's involved. What labs are you running for those?
Yeah. First things is we're looking at a complete blood count or a CBC, and ideally if we have a few of them so we can look at patterns over time. We're looking at their white blood cells, we're looking at their neutrophil to lymphocyte ratio, which are two different types of white blood cells. That can sometimes tell us, is there a heightened immune response going on, especially if we see kind of that fluctuation. 1 month it's good, 1 month it's high. We're looking at inflammatory markers. So there's a few inflammatory markers that we can measure in the blood, things like C-reactive protein or erythrocyte sedimentation rate. That doesn't mean that if those come back normal, that someone doesn't have an inflammatory process happening, but they're two that we have the ability to measure. And if those do come back elevated, then that gives us some data and information there. We're looking at a liver panel, so we do know that there's different patterns that can show up in a full liver panel, so not just ALT, but ALT, AST, GGT, and bilirubin. And same thing, looking for patterns over time if we have access to that, otherwise just as a starting point. Typically looking at urate, and we use that as a functional marker to tell us a little bit more about the gut microbiome and what might be happening there. We can look at some specific immune markers, so an ANA, just general marker of autoimmune. We're looking at thyroid antibodies. We can measure what's called C3 and C4. So these are two complement proteins that's part of our innate immune system. My husband's in the military, so I always think about it as like the guys that they're willing to just like throw it onto the field, but they're not being sent out with a very specific mission. So they're just like, hey, you go test the waters.
Yeah, exactly.
see what happens. So I think about the innate immune system that way, is it's not very specific, but it's kind of that, hey, let's kind of test and see, is there something that we have to defend or identify shouldn't be here? So those are things that we can often look at too if we want to understand how different parts of the immune system might be behaving in different ways. That's the starting point. This is probably the other episode where we're looking to understand clotting patterns in INR and PTT, or you're going down the realm of antiphospholipid syndrome, which is technically a clotting disorder, but there's an autoimmune component to that as well. Insulin is always involved anytime.
Anytime.
Start
and end of that sentence. Anytime.
So that's definitely relevant to measure and assess. Yeah, that's normally where I'm starting. Sometimes the CA-125 if I think it's going to give me information. So CA-125, we'll typically test it when someone's on their period because it's a marker of pelvic inflammation. So if someone is actively bleeding, it's going to be a more sensitive time that we might see an altered reading to that, which would maybe give us a little bit more information. I run it less often now, though, because out of complete transparency, I've just seen so many times where it comes back normal and it just hasn't been an accurate assessment for guiding treatment decisions, that I'm like, if I'm still going to treat as if there's some sort of pelvic inflammatory disorder, or again, the immune system is involved, I don't really need this number to be able to make that decision for me, nor if it comes back normal. And I always warn patients, like, this doesn't mean that this isn't there, but if it comes back elevated, sometimes it's a gateway that we can use if we need the medical doctors to open a door for you and push something in a further direction. But I've just seen so many cases where it comes back quite low, but then someone still has, say, stage 3 or stage 4 endometriosis or more advanced endometriosis. So I would say I run it less often now, but technically that could be an option. And then assessing whether or not we need, like, that's normally starting point, just because it's easy to go for blood work. And then from there, do we need vaginal microbiome testing? Do we need some of those other layers to understand a little bit more potentially what bugs or viruses or fungi or whatever that we're working with that might be impacting the immune system. But oftentimes we can gather that some of the viral serology from the fertility clinics, or certain clinics, are running that a lot more often, and we can look at specific antibodies to different viruses. So whether that's CMV or cytomegalovirus, there's a whole handful that they'll look at. Fifth disease, they'll typically do standard STI testing from there. Yeah.
And I think the important thing is we just listed a lot of different factors, and that's still a drop in the bucket of the immune response. The mass majority of things we can't test. And so we are having to use our clinical judgment and statistics to say the reality is this is probably immunological if you've gone through this whole other process. Do I know exactly what immune dysfunction? No. Is a test or functional test going to give me that answer? Maybe not, to be honest. But that doesn't mean we don't still have such a huge swath of things we can do and investigate, which I think is what's so important to understand, is a lack of a diagnosis or being diagnosed with RIF or RPL, or again, even just unexplained. That doesn't mean you can't get help. It means that you need someone who's looking in a different direction or looking in a different place to get you that help. So I feel like this has been a really solid deep dive into the immune system. We're high leveling it, right? Because so much of what happens here happens in talking to someone, because the immune system is such a huge variety of conditions and there's such a huge variety of things. It's hard to just come up with a list of this is how we would do this and this and this, right? We really are using our clinical expertise. But is there anything else that you think is important that people know about this topic before we wrap up for today?
I think just the awareness that it could be an option. I think that's the biggest thing. Is if you feel like you've done all of the standard testing and you're still not getting pregnant, just to even know, okay, what else is out there for me to explore? Because I think that's the biggest thing. And I've heard that from so many patients, I'm sure you have as well, is I didn't even realize that this was a whole nother arm that I should be looking at or that I should consider, because sometimes they're told, oh, we're at the end of the road. and everything's normal. There's nothing else that could be playing a role. So I think it's more so just opening that conversation to say, okay, if you've gotten all the way here and you're still not pregnant, here's all the other things that we actually can look into and that we want to understand and investigate and support, whether we can get concrete answers through testing or whether it's based on signs, symptoms, and your personal health history that's guiding us towards, okay, this is a factor to some extent. Let's dive in and start seeing where we can get with this when we dive into working to support it.
Yeah. And I can't count the number of patients that have been through 3, 5, 7. I have a couple of patients, 10 rounds of IVF, right? Plus the IUI, plus trying beforehand. That is such an insane amount of procedures people have been through to then come into our offices and say, what's been done for your immune system? And the answer is nothing. They've tweaked their meds protocols, but not anything from an immune perspective. It's all hormone suppression, try this, try that, right? And I now, again, couldn't count patients who have had their second baby in 2 cycles, right? Because they were able to understand how to manipulate their immune system. They did the work with us, plus they did the work with fertility clinics in many situations. They found the right one. And they were found the right one.
I know, that's why I was like, key.
Yeah. And then they were able, between the 2 forces, to conceive twice in a row on 2 transfers. So it's not going to happen for everyone. And I don't want to paint a false picture, but you do deserve the conversation. And that's what I think you and I are both so passionate about.
Yeah. And I think just to highlight on that a little bit, because I've had patients get pushback from certain clinics where they're like, that's not a thing. The research isn't robust, that the immune system's a bigger factor. I really encourage patients to often get a second opinion in those situations before they transfer another embryo, because I'm like, just because this clinic is saying, nope, that's not a thing, that doesn't mean it's actually where the science and research kind of leads. That's their opinion, but that doesn't mean that's where the road has to stop.
And like, not a thing is not a medical term. I would just like everyone to be on the same page about that here. Not a thing is an opinion. And just because someone gets fired up about their opinion doesn't mean that works for you. It doesn't mean that's right. You know what I mean? My husband thinks Pokemon are great. That's his opinion. I don't know that's a fact, right? And it may sound really silly to compare Pokemon to health. It's not actually. The things we hear on a day-to-day basis is crazy. And these are people's opinions, and they will fight you to the death about it. But it's like choosing a team. How do and why do you choose a sports team based on random statistics? It doesn't make any sense, but we have these alliances to theories in our lives, and we're stuck because we're stubborn and we're human. And that doesn't mean that you can't choose a different team, ask a different question, get a different opinion. You have every right to do it. And anyone who makes you think that's not okay, you really should reconsider that, because I think at the end of the day, we all should have the same goal. The best evidence for the best patient in the best environment at the best time. And sometimes that's very little evidence in an unclear environment that's not getting the outcome you want. And it's been a hell of a long time. And so let's just do something different.
Yeah, agreed.
Okay. Well, on that note, we will wrap up for today. We still have 2 more episodes. We're going to be talking about circulation. We're going to be talking about so much more. So yeah, until next time, have a great day, everyone.
Thank you so much for listening. I hope that you had as much fun as we did. And if you loved today's episode, share it with a friend and leave us a review. That is how we spread this message, and that is how we are going to revolutionize healthcare in Canada for women. Have a beautiful day and be well.